All right, good afternoon, good morning, good evening, everybody. Welcome to another CPS VMR today. It'll be me today, Ravi, and Kirtan actually will be helping me along the way with some of the discussion as well. So we're looking for a case discuss or a case today. If anybody has a case prepared or does know of a recent case that they can also contribute to, would really appreciate that. And we have today doing teacher points, Sammy, who's also here today. And I'll let Sammy, and then Madalena is going to be doing scribing. Madalena, Sammy, but while we wait for a case, do you want to unmute your mics and just introduce yourselves? And then I'll have Kirtan introduce himself.
Sure. Hi, welcome everyone. I'm Sammy. I'm gonna be doing the teaching points today. I'm from Austria, and today is the first really hot day here in Austria, so I'm sweating already. And yeah, I think this will be a hot summer, and very hyped for the discussion today. Can't wait for Ravi and Kirtan to spread their wisdom and teach us all, and happy to learn with you all together.
Yes, and hello everyone. My name is Madalena. I am a third year medical student in New York, but almost done with my third year, just a few more weeks. And I'll be scribing today, as I said. So excited to learn from Ravi and Kirtan, and very happy to be here.
Good morning, friends. Thanks for introducing yourself. And I wanted to thank Madalena, Sammy, Sierra, and Franco, our dear team members, even Hans who are present here today. It's always a pleasure to see you again. And I'm so excited for today's case. And I wanted to comment on one thing which Sammy mentioned, talking about the heat. So today in India, where I stay, our temperature was around 48 degrees Celsius. So it was like highest we ever had in like last, couple of months or so. It has been terrible, 48 degrees. Can you imagine? It was so hot.
Absolutely. It's I'm here in Baltimore, Maryland, which is the mid-Atlantic eastern seaboard, and the temperatures, I guess Madalena's north to me in New York, and the temperatures are now finally getting warmer. So we did have a little bit of a cold spell, but it's nice to have some sun, and looking forward to having a good late spring and summer. I can't even imagine, Kirtan, I can't even imagine 48 degrees centigrade. That's like sweltering hot. All right, they're still looking for a case. Did anybody type in the chat that we do have a case?
And I just wanted to encourage everyone that even if you don't have a well-prepared case, it's totally fine, because we like to learn from the things. So even if you have the brief outline of the case, only few symptoms here and there, still we can work on it. So please don't hesitate to share your knowledge and your wisdom with us through a case if you have so.
I know Franco had a case before. Any cases that you may have as a backup, Love? Or Hans? I also see a few other frequent members, Victor, Camilla, Amir. How you guys doing? Oh, Amir writes doing great in the chat. Yeah. Kirtan, have you seen any, or have you been in the clinic, seen any recent cases? Maybe
Yes,
if you
so
have a case.
Yes, I actually had been to the clinic, and there was an interesting case, but actually we were saving it for the subsequent podcast episodes. So like,
oh, okay. Yeah.
Like, can we present it or not? Yeah.
Definitely save, please do. Yeah, if it's for the podcast, we won't discuss it here. I have a bunch of cases, but I don't want to discuss because otherwise I won't be able to then facilitate. But anybody still waiting, eerily silent for a case?
And meanwhile, Dr. Singh, while we are waiting for a case from our archives, maybe, our team members will help us. Can you reflect a little bit about some recent experiences from the clinic, like, any interesting case or any interesting patient encounter that you had, very briefly, so that we can wait for case till then?
Yeah. Let me just bring up. I just came back from conference, and I spent a great deal amount of time just looking at clinical vignette posters. Let me just bring up something. I actually took pictures of posters. I'm still looking at the chat to see if anybody has a case. Oh, hey, so Kirtan, remember I sent you a picture that we did that one VMR where there was a case of ear pain, right? So while I was in Chicago at ACP, there was actually a poster which caught my eye, which was called Catching an Earful, a curious case of relapsing polychondritis. And this case I remember you talking through that case and describing cauliflower ears. So it really stood out to me seeing the picture of cauliflower ears. And many times, from my experience, I do some jiu-jitsu. I'm not a great expert at jiu-jitsu, but I see people getting trauma in the ears, rugby players, and they tend to get, I guess, hemorrhages into the ear, and then they get these malformed ears, which are called cauliflower ears. But with relapsing polychondritis, we do see this ear abnormality. So this was a 66-year-old patient with history of right-sided squamous cell carcinoma, stars post resection, and coming with recurrent right auricular pain, swelling, and erythema. And during this time, for about 5 months, they've been treating the patient with antibiotics and various antihistamines, thinking it's an allergic reaction or maybe it's an infection, but nobody's really taking a close look and looking at the malformed ears in sequence as it's getting worse, and it's screaming out to us that we've described before, we've discussed the case before, relapsing polychondritis. And you would look for other patterns of involvement, which could be saddle nose deformity. In that case, you may get a non-erosive cartilage involvement of the joint, so joint pains as well. And you may also get voice change. I remember in that case that we discussed, the patient also had hoarseness of the voice. So this was a very interesting case of relapsing polychondritis. I've never seen a case before, but having discussed it and then learning through a schema, it definitely is something that I'm on the lookout for if I do see somebody come to the clinic. Well, I see more of Frank sign, right? Everybody know what Frank sign is. I look at ears when I go see patients, definitely observe their face, the eyes, look for raccoon eyes or things like that could really jump out at you. Look at the ears, like the cauliflower. Look at the crease at the earlobe. So anybody familiar with Frank sign? Oh, Hans has a old case. Okay, but we'll just finish that comment. Kirtan, are you familiar with Frank sign?
Yes, so actually, fortunately, a couple of months ago in one of the medical journals, in the medical image section of that, I learned that when you have Frank sign, that is, you're in a diagnostic like for cardiovascular disease. So if you look at the earlobes of the patient, and if you see a kind of a diagnostic crease along the earlobes, then it suggests that they are at elevated risk of cardiovascular disease. So they can get strokes, they can get MI, and nobody knows why. I mean, why there is a line on the earlobe in the diagonal shape, nobody knows, but it was the Frank sign. And anything else to add, Dr. Singh, to that?
Oh, that's absolutely brilliant. Yeah, and Fatima also mentioned increased risk of cardiovascular disease. So it's very interesting when we see that. It's just practicing the observation of the patient from the face downwards. And it's always a nice little finding that you can demonstrate. And then you can bring out the old article. It was a Dr. Frank, I guess, that had come up with this first observation and found the association of cardiovascular disease with these patients. Okay, Hans, are you able to generously present this case of yours?
Yes, I can present the case if you like.
Okay, that would be great. Thank you. Appreciate it.
Yours are always so interesting, so I'm hoping this one might keep you busy for a while. So we're starting with the chief complaint, which is increasing fatigue. And then I'll give as a second aliquot the HPI and maybe the past medical history.
Okay, Kirtan, would you like to start with this very interesting chief complaint?
Sure. So, firstly, thanks for saving us today, because we were really hoping that we will get a case. So thanks for saving us. And now regarding the fatigue, so as we know that fatigue is a very non-specific complaint, but still having a proper framework to approach the fatigue can help us regarding the diagnostic process, because it's very easy to shoo away such complaints like headache, fatigue, myalgia, malaise. But if you have a framework for it, then definitely it can guide you along the way. So how we can approach the fatigue? So you can ask very basic questions, that if you yourself were fatigued, then what are some of the possible causes that you were attribute yourself to? So for instance, one of the most common causes of fatigue can be anemia. So things like as low hemoglobin as possible can contribute to the fatigue. So that's the one part, that can anemia be contributing to the fatigue. Apart from that, we can talk about the systemic processes, because any sort of inflammation in the body, whether it's due to infection, whether it's due to autoimmune process, or whether it's due to increased turnover of the cells, so kind of like, neoplastic or malignant etiology, then it can also contribute to the fatigue. Then you can, apply the metabolic aspect to it, that what if your body is expanding more on the metabolics rather than gaining from the food that you are consuming. So how your body can expenditure more energy. So one of the ways to look at it is either you are not absorbing the food properly, or maybe you are absorbing the food properly, but you are not able to, digest it properly. So what are some of the causes of malabsorption of the food? Is there evidence of protein malabsorption? Is there evidence of carbohydrate malabsorption? Is there evidence of fat malabsorption? So that is the intake part. And then the metabolism part, that if the patient has neoplasm, if the patient has some autoimmune disorders, then your body will start expending those energy on those aspects, and that's how you will get fatigue. Apart from that, again, if you look at the vitals that we always get when we first see the patient, then we think about the oxygen, we think about the blood pressure, we think about the respiratory rate. So things like hypoxemia, things like hypercarbia, things like chronic hypoglycemia can contribute to fatigue. Then apart from that, we also look at the arterial blood gas or venous blood gases. So things like acidosis, things like high NNK metabolic acidosis or normal NNK metabolic acidosis can also contribute to fatigue. So all these, all the basic things sounds vague, but if we have a framework for it, then we can approach that. So I guess that's what I will look into, checking the vitals, making sure what's in the history, what's in the HPI, and then we can move ahead. And Dr. Singh, can you tell us how we can refine this process before we can get the HPI and past medical history?
This is absolutely wonderful, Kirtan, what you just mentioned, because fatigue is very non-specific, but I really don't know what to prioritize here, because we do need more information. But what really catches my eye and what I really will track is increasing fatigue, which if you think about conditions that it should immediately trigger, thinking about what came to mind was a neurological process like myasthenia gravis, where the fatigue or the exercise intolerance gets worse throughout the day. So I'm prioritizing maybe neurological processes. There's other things that you could have movement disorders that could come to mind as well. But I can't help then just anchor on to endocrinopathies, ones that can also come to mind, adrenal insufficiency, hypothyroidism. The anemia is I've seen from experience, anemia definitely can manifest as increasing fatigue. But things I would want to know is over the time course of the fatigue. Is it a fatigue that's happening throughout the day, or is it just one day the patient had fatigue and now several days later the fatigue is getting worse? And then also need to identify accompanying symptoms. Is there dyspnea? Is there dizziness? Is there any chest pain? Is there pain anywhere else? Is there accompanying fever, which may signal inflammation? There's some really great thoughts in the chat where people are highlighting some of these disorders. But what Kirtan has put together right here is a great mechanism to start going through fatigue and trying to identify potential causes. So Hans, next aliquot.
Yeah, that's an awesome discussion already. And I will continue with the HPI and maybe the past medical history. Another patient, it's a 24-year-old female. She has no past medical history and she was admitted to the hospital for increased fatigue. Since the birth of her first child 4 years ago, the patient has been feeling increasingly fatigued. For 3 to 4 months, the fatigue has been so pronounced that she could hardly manage her daily household chores. She became breathless even on slight exertion, had a ringing in her ears, and everything went dark for periods. For 3 to 4 months, she had noticed, in addition, a tendency to bleeding of the gums, but otherwise there has been no tendency of hemorrhage. Patient denies yellow discolorization of the skin, sclera, or dark or bloody urine at any time. So that's the HPI. And if you wish, I can add the past medical history as well.
Yeah, please, Hans, that would be awesome if you can give us past medical history.
Okay, the past medical history. Birth of her first child 4 years ago. She has normal menstruation and no other illness. Then the family history. No diseases of the blood known in the family, at least to the patient. Social history, she's married, she's a housewife. She denies alcohol, tobacco, or recreational drugs.
Awesome.
And any health-related behaviors, or should we stop here? Okay, I guess we'll stop here, Hans. Is that fine? Okay.
Next will be the physical exam and the.
Okay, yeah, we'll stop and maybe grind it out a bit more with some of the data that you gave. So, Kirtan, I just kind of will add now with this HPI. This is a young person who's coming into the hospital. So that means admitted to the hospital, there must be something significantly going on in the background. There's been fatigue since the birth of the first child. So have to link the birth of the child, what may have manifested since the birth of the child 4 years ago. So 4 years is an extremely long period of time. If this was something sudden, I would be very, very concerned about that. But this has been a slow, gradual buildup. But something must have happened in the last few weeks or months to then have the patient then come to the hospital and not seek medical attention prior to that. So this fatigue is now worse, and there's associated shortness of breath. So we now have to link fatigue and shortness of breath, and this really screams out at this point, or I want to highlight anemia, which you had mentioned before, and especially with slight exertion. This episodes of ringing, one of somebody in the chat, Amir, had asked for elaboration on that. I'm not sure if this should be prioritized or highlighted. It could be something that's accompanying. So ringing in the ears could be many different things. I'm not really going to do the cognitive legwork because this just could be something that's secondary to what the primary process is going on. There's periods where everything goes dark. So that's very alarming. And that may also indicate a cerebral hyperperfusion process that's going on. Gum bleeding. Kirtan, I'll let you tackle that. That's very interesting. That opens up the doors on a whole nother topic there, but I'll leave you something to discuss there.
Sure. Thank you so much for laying out that framework. And I agree with Dr. Singh's approach that 4 years is a long time. So if you think about some of the possible complications of pregnancy, like postpartum eclampsia, postpartum heart failure because of peripartum cardiomyopathy, then you would expect that either patient would be deteriorating so suddenly, the process won't go on for 4 years. So those things are less on our mind. Now, anemia is really interesting. And I just want to point out one thing that Dr. Singh alluded to in the first report, that what if there is component of endocrinopathy? And if you think about it, then we know that in patients who are pregnant, sometimes the pituitary blood supply can't, accompany the size enlargement of pituitary gland that happens during the pregnancy. So you can get what is known as postpartum pituitary necrosis, so which is known as Sihan syndrome. And I remember this because Dr. Rabi actually eloquently discussed this case a few months ago on one of the VMRs. And that VMR was also very similar to our case, that how patient has these symptoms for on and on for many years, and that can later on manifest as fatigue because of hypothyroidism and adrenal insufficiency. So the point which Dr. Singh raised in the first aliquot is absolutely important. But now I also agree that it's a rare diagnosis. So we also have to think about some other possible causes. So another interesting thought is that maybe sometimes after pregnancy, you get what is known as the empty sella syndrome, in which, sometimes the whole pituitary thing kind of shrinks, and in the sella turcica of the brain, only the fluid is present. And why I'm alluding to it, because if you have the increased intracranial pressure, then sometimes you can get the tinnitus, as well as you can get the blurring of vision because of the papilledema. And since it's a grave sign, we also need to get a fundoscopy as soon as possible to make sure that patient is not in imminent danger. And now regarding the bleeding part, I agree with Dr. Singh that it's a strange possibility, but maybe you can think about it like this, that pregnancy is a red herring. Maybe the patient has something else and pregnancy has got nothing to do with it. So what can manifest in a 24-year-old which can lead to bleeding? So firstly, since the bleeding is from the gums only, we have to make sure that the patient is menstruating properly, the patient is not, bleeding from other orifices of the body. Like, is there evidence of hematmesis? Is there evidence of hemoptysis? Like, is the bleeding localized to gums only or not? That's our first question. And then, we can look at the nutritional deficiencies, like scurvy, like vitamin K deficiency, they can contribute to bleeding. But again, since it's in the orofacial part, we also need to make sure that cavernous sinuses are functioning fine and there is not component of the venous occlusion, which is contributing to the epistaxis or the gum bleeding. So we have to be vigilant about that. And as usual, we need to get CBC to make sure that we are not dealing with some sort of bone marrow process like leukemias or hyperproliferative bone marrow, which can contribute to the bleeding. So I think that's our approach now. So now, Dr. Singh, do you think that we can discuss a little bit more, or maybe we can get physical examination next?
Yeah, I just want to add something now. This is phenomenal what you've gone through. You've gone through a journey through different causes of this gum bleeding, and what may be potentiating that, the platelet disorder, the coagulopathy disorder, the coagulation factor. So what's interesting is if you glean through postpartum disorders, you can get an acquired hemophilia condition or antibodies to the coagulation factor. So I'm very interested. I will be looking for coagulation tests for abnormalities. And this is where something I don't routinely go into, but we do the mixing studies to see if there is an antibody, if the PTT is prolonged, we will look for correction with giving some sort of corrective factor, which could be plasma and so on. And if it doesn't, that means there may be an antibody. So I'm very interested. When you have bleeding with gums, that does signal patients that have hemophilia, they have some platelet dysfunction disorder, because it's not spontaneous bleeding, but usually it may be exacerbated by just some friction, which could be promoted by brushing the teeth or other sort of dental maneuvers. You go to the dentist and after extraction of the tooth, you have excessive bleeding. So this definitely is something I'm going to track, and maybe, we were thinking anemias, and the cause of anemias is pretty vast. You can enter the river of blood that I always love that example that Rabi always tends to discuss on VMR or the podcast. So in the river of blood, there are many, many different causes for bleeding. So you can have the platelets that have some sort of dysfunction. There could be also lack of platelets also as well. So thrombocytopenia. So we're going to definitely look for these in the lab tests that Hans will give us in the next aliquot or the aliquot after that. So we'll go straight to the physical exam.
Yeah, the physical exam, the vitals are all normal. So that's quickly done. Then general, it's HEENT. We see a pronounced anemia of the skin and mucous membrane, but no jaundice, no glandular swelling, and no lymphadenopathy was present. Heart and lung are all within normal limits. Abdomen, unremarkable. no hepatomegaly, no splenomegaly. Extremities are also within normal limits, and the neuro hasn't been done, but it's normal too. I can continue with the labs or just stop for a while and then continue. That would be allocat number 4.
Yeah, let's this exam is very, very remarkable. Let's stop here before we look over the significant findings that you have here. But Keithan, would you want to start with the physical exam, and then I'll chime in after?
Sure. So, firstly, the vitals are really helpful here, because if the patient was bleeding in a severe amount, then you would expect that the vitals would be unstable and you would need to prioritize the management over the diagnosis aspect. So I'm glad to hear that patient is doing fairly well, patient is stable, so bleeding is not severe. And another interesting thing about the examination is that we have to focus on the negatives as well as the positives. So if you think about the negative aspect of the exam, the patient has no lymphadenopathy, the patient has no hepatosplenomegaly. If you look at the positive signs, then we have the evidence of pallor. So the presence of pallor kind of, cements our hypothesis that the anemia is definitely contributing to the fatigue, the shortness of breath, and even to the blurring of vision, because we know that when you have anemia, you get these vague symptoms like headaches, syncope, dizziness, and everything. So that can contribute to the blurring of vision as well. But now how we can link the negative findings and cement our hypothesis of bleeding. So if you think about certain lymphomas and leukemias which can manifest at such young age, so things like ALL. So if you think about ALL, then classically ALL tends to present with hepatosplenomegaly along with the lymphadenopathy. Now in our case, we don't have that. So that doesn't mean that it can't be ALL, but it definitely lowers the suspicion for ALL. Now regarding the AML, it's definitely a possibility, because usually AML doesn't present with splenomegaly or lymphadenopathy, whereas CML does. So AML is a possibility, but you also have to understand the base rate of the disease, because AML is classically seen in people above the 50 years of age, and we have a 24-year-old female. So that's also on time. What else can contribute to low platelets along with the low hemoglobin? So maybe there is a possibility that the patient has aplastic anemia. And as Dr. Singh mentioned, that after pregnancy, you can get these all sorts of antibodies which can target your own cells and can lead to numerous manifestations. So acquired hemophilia is one excellent example of that. And things like pure red cell aplasia and aplastic anemia have also been linked to the pregnancy, because sometimes those antibodies from the maternal circulation can cross over into the body, and they can cause all these sorts of things even in the fetus. So like it can happen in female body as well when there is pregnancy. So aplastic anemia is definitely which can present with pallor, with low platelets, and without evidence of hepatosplenomegaly or lymphadenopathy. So that is absolutely essential. And lastly, I would like to make just one pearl, which I learned during my rotation in the hematology, that never discharge any patient who has hematology problem without getting two things. One is the peripheral smear, and another one is reticulocyte count. So you always have to get those things, because those two things can help you go a long way into the diagnosis. Like they can be so helpful that sometimes it can obviate the need to get bone marrow biopsy as well. So I would end my discussion with that point, that let's get the peripheral smear, let's get the reticulocyte count apart from all the CMP and BMP, and I'm sure that will help us move ahead. So Dr. Singh, what are your final thoughts before we move to the basic labs?
Yeah, I just loved how you picked apart different potential disorders. We've gone through the journey of leukemias and how you've given some pearls about hepatosplenomegaly could indicate or could be a signal for that. But then again, these are processes which are dynamic. So the patient could be early in the process before like an extramedullary hematopoiesis has had a chance to set in. But just going back, even though many times we look at the vital signs and we think like they're normal, so they're not really indicating or screaming anything out to us, but it doesn't appear this is a really significant bleeding. But then again, you go back and look at the HPI, patients reporting a multitude of different complaints that are associated with severe anemia. So I'm kind of interested in the vital signs. If Hans had them, I would look for at least a narrow pulse pressure. So we talk about wide pulse pressure, but a narrow pulse pressure, if that is something you catch in the vital signs, that immediately could indicate that there's a volume issue, and volume could be Could it be just fluid or lack of fluid deficit from volume loss? Could it be anemia deficit as well? So, or blood deficit. So those things could immediately help support your hypothesis here. But then again, this is a 24-year-old patient, and young patients actually can at least be able to mask some of these findings as well. So you have to be really careful with a young patient. They are able to compensate to the extreme, and when they get to the extreme, that's when everything then just falls apart. So usually I would at least want to see if there was tachycardia and that narrow pulse pressure. With anemia, you're not going to really have a severe pulse ox deficiency as well. But going back to the pallor of skin, mucous membranes, that is indicating sometimes palmar crease pallor can also indicate a very low hemoglobin. There's no jaundice. So right there, to me, that indicates I don't have to explore the domain of hemolytic anemias. Again, it could exist in as a possibility in this patient's presentation. But having jaundice would then allow us to then explore the domain of hemolytic anemias as a cause for this patient's what we think is a low hemoglobin. So we're anticipating quite a bit there. But yeah, let's go back to the labs then, Hans.
Yeah, the labs, the erythrocytes, they were actually low with an HB of around 10%. Then we have a white blood cell count, again very low, 1,400. Lymphocytes, 40%, 55% monocytes, 5% monocytes, yeah. Then we have thrombocytes, platelets, 27,800, so very low. They also did further labs because she was bleeding. So we have a bleeding time of 14 minutes. Normal would be 2 to 7 minutes. We have a clotting time of 4 minutes and 10 seconds. The normal range would be 10 to 13 seconds. So it is very high. We have a prothrombin time, which is normal. And I will also give you the reticulocytes, which while she was in the hospital was measured between 0.8 to 6.2%. So that's a normal range of reticulocytes, rather a little bit more on the higher side. Then serum bilirubin I have as well. That's 0.8. And the iron panel was within normal range. Shall I give you the bone marrow exam as well, or shall we stop here for now?
I think hence we can stop here because we already do so much data that we can dissect along with Dr. Singh. So I think we can stop here.
Yeah, Kirtan, you want to tackle the CBC? I'll tackle the coagulation.
Yes, I think that would be great. Maybe you can comment on the reticulocyte count part and the coag part, and I would take the WBC and the hemoglobin part. So now our hypothesis is getting stronger and stronger that maybe we are dealing with a bone marrow process and which is compromising all the three lineages. That is the WBCs, hemoglobin, and I mean the RBC part and even the platelet part. So now what can be the possible etiologies for such conditions? So if you think about it, in order to make the hematopoietic stem cells, in order to make the RBCs, WBCs, and platelets, you need the raw material, right? So what is that raw material? Our bone marrow requires vitamin B12. Our bone marrow requires folic acid, and our bone marrow requires the copper. So deficiencies of all these three vitamins and minerals can contribute to the pancytopenia. So we have to, explore the history again. We have to go to the patient's bedside. We have to ask the patient and their relatives that how has been their diet, like are they eating properly? Is there something that may be contributing to malabsorption of these nutrients, and that's why we have pancytopenia, because common things are common, and these nutrient deficiencies can go hidden for a long time before you order the serological test for those deficiencies. So exploring these three common things, vitamin B12, folate, and copper, would be absolutely essential. And now again, regarding the reticulocyte count, which Dr. Singh will comment on later, we can prioritize that whether this could be simply vitamin deficiencies Or is there something more? What if there is peripheral consumption of all the three cell lines? What if the patient has splenomegaly and that's why the patient has pancytopenia? But from our examination, we know that the consumptive process is less likely because the bilirubin was normal and there was no evidence of splenomegaly. So that's one part. And now lastly, what can infiltrate the bone marrow apart from the lack of raw materials? So it could be the neoplastic cells, it could be the infections. So, all the granulomas. So there are numerous organisms which can cause granulomatous infiltration of the bone marrow and can contribute to the pancytopenia. And lastly, the fibrotic disorders. So ranging from primary myelofibrosis to secondary bone marrow fibrosis, which can be seen in patients who have HIV infection, which can be seen in patients who have rare variants of multicentric Castleman disease, like the TEFRO syndrome, which stands for thrombocytopenia, anasarca, reticular fibrosis, renal dysfunction, organomegaly, and then some rare disorders like gray platelet syndrome, Gaucher's disease. So we have to make sure that there is no evidence of fibrosis in the bone marrow, which is contributing to the pancytopenia. And after we have ruled out these basic etiologies, we can move to the next part to finalize our diagnosis. So Dr. Singh, can you teach us now that how we can incorporate the reticulocyte count and the coagulation parameters into our thinking process?
Kirtan, I loved your walkthrough of pancytopenia and all the possible disorders and TEFRO syndrome. Oh my gosh, I always forget that one, but something I have to remind myself. Yeah, it's very interesting. Is my head spinning? And at this point, I kind of can't wrap my head around what exactly is the process, but you know what, we'll slow it down and start tackling each parameter. You really nicely went through what we have a state of pancytopenia here. So it's not just the platelets, but the hemoglobin is also low and probably a manifestation of potential bleeding. Although we don't have any signature of large volume bleeding, so it may just be a bone marrow issue that is at play here. Okay, bleeding time. Normal is 2 to 7. What exactly is bleeding time to me? What I remember is that there is actually a primary platelet disorder that's involved here, or could it be a vascular issue as well? So there was a lot of discussion of scurvy potentially in the chat, which could also increase the bleeding time. Clotting time, it's high. I don't remember the normal values, but clotting time just means how long does it take to make a clot. So that can be measured by the PT and PTT. So this means it's not just a platelet disorder that's at play here, but there could also be clotting factors that we have a problem with here. PT is within normal limits. So PT, if we just do a walkthrough of the extrinsic, intrinsic coagulation cascade, PT is a measurement of factor 7, and factor 7 maybe it's normal here. So vitamin K dependent factors, the PT will be within normal limits. Retic count is within normal limits. So that's a little alarming. That should draw our attention back into the bone marrow and then see what is going on. Why isn't the bone marrow not responding appropriately to loss of hemoglobin, or loss of blood cells? Iron panel within normal limits. So we're not in the domain of iron deficiency anemia, microcytic anemia, and so on. So I would look for a chronic blood loss to manifest with iron deficiency anemia. So when you have iron deficiency anemia or macrocytic, microcytic, normocytic anemias, you tend to have a low reticulocyte count. So this should signal we're at the branch point where you could have issues with building blocks. Basically, I think about it as building blocks. So macrocytic folic acid and so on, normocytic anemia of chronic inflammation and others. And then you can also have microcytic, and I use the tails mnemonic. So thalassemia, anemia of chronic inflammation, iron deficiency anemia, sideroblastic anemia, and lead toxicity. So those would potentially cause microcytic anemia, but we don't have an MCV. Yeah, we didn't get an MCV. So that's the coagulation factors are telling me that there is a platelet or vascular wall integrity issue, and there could be coagulation factor issues at play here. Hans, are we hot in regards to weeding through the labs here, or are we missing something?
I think I'll give you the bone marrow. And if you wish, I don't know whether I can get it up the screen. I made myself a schemata for pancytopenia and bone marrow. So the bone marrow exam, it showed some modularity of hyperplastic bone. So we have a hyperplastic bone marrow and some areas seem to be normal. I have no indication for any blasts or any other abnormalities, so just a hyperplastic bone marrow. I also have a urinalysis, which was done several times, and it's most of the time unremarkable, no blood detected, and at another time they found a few erythrocytes with weakly positive reactions for hemoglobin. An FOBT, a fetal occult blood test, was done, and there was no blood in the feces. And I think that's all the tests I have, except for one more lab test, which will reveal the diagnosis.
All right, Kirtan,
Dr.
you
Singh,
can take
what do you
first stab
think?
at this. Oh, Kirtan, go ahead. You can take first
Yeah,
stab. And
sure.
then...
Okay, thank you. So, now we have two interesting findings, that the bone marrow was hypoplastic and there was no evidence of blast. And if we remember from the previous aliquot, then the reticulocyte count was low. Now, before I jump into the differential diagnosis of hypoplastic bone marrow, I just wanted to quickly comment on one thing, which I actually learned from the VMR itself, that whenever we think about the reticulocyte count, sometimes you may see that the patient has reticulocyte count of 3%, and still the bone marrow will show the hyperproliferation. So you might be thinking that, well, the normal range of reticulocyte count is 0 to 2%, and now we are getting 3%, then why still there is hyperproliferation? Because the reticulocyte count percentage are not the true, kind of marker of the bone marrow proliferation. We have to go for something known as RPI. It stands for reticulocyte production index, because when you have the hematocrit, which is lower than the normal, then you have to correct the reticulocyte count based on the expected hematocrit. So for instance, in our case, the hematocrit is 10, like the hemoglobin is only 10, but usually you would expect something around 12 or 14. So you have to divide the 10 by 14, and then you will get the corrected reticulocyte count. And then you also have to account for another correction factor, which is something strange that we see in bone marrow. And after that, accounting for the correction factor, you get what is known as the reticulocyte production index. And then only you can count on the fact whether it is hyperproliferative or hyperproliferative. Now, in our case, it's definitely hypoproliferative. Now, regarding the differential diagnosis of hyperproliferative bone marrow, so there are two main possibilities. So one of them is aplastic anemia, and another one of them is hypoplastic variant of myelodysplastic syndrome. Now, usually in myelodysplastic syndrome, you tend to get extensive proliferation of the blast cells and immature precursors in the bone marrow, but that's the classic variant of MDS. You can also get hypoplastic MDS, in which although cells will be immature, but the bone marrow will not be filled with all sorts of precursors. But the thing is that that kind of variant is more common in elderly people. Again, because MDS is a stem cell disorder, so it kinds of comes along the aging process. So it is unlikely that we will see it in a 24-year-old female with no past medical history and no relevant significant family history as well. So aplastic anemia is definitely the chief contender here, but still, to make sure that we are not missing anything, and because of the potential involvement of pituitary, we would like to get TSH, T3, T4 cortisol levels, and also the common three elements that we talked about earlier, vitamin B12, folate, and copper, to make sure that we are not missing any potentially reversible causes of this syndrome. So I think aplastic anemia is definitely something that I would keep in my mind moving ahead. And now, Dr. Singh, where are you putting your money at?
I have no
May
money
I
to put.
interfere just quickly, because I didn't pronounce it correctly, hyperplastic. So we have too many cells, but it was a good thought. So we discussed both. My apologies. That's my fault. It should be hyperplastic.
No worries, Hans. So now, for hyperplastic, of course, the things will change a little bit. So now, of course, we will think about the myelodysplastic syndrome. We'll also think about the possibilities of various leukemias. And again, now the B12 deficiencies, the folate deficiencies come at the foreground, because usually in those cases, you tend to see the hyperproliferative bone marrow in B12 deficiencies and folate deficiencies, and even PNH, because we know that PNH is a stem cell disorder. And in PNH, you also tend to get the pancytopenia. And the only way to diagnose PNH is to get the flow cytometry to make sure that CD55 and CD59 is not present on your stem cells. So, and PNH can present with hyperplastic bone marrow along with the evidence of all three lineages being going down. So those are our chief possibilities. And I think bone marrow biopsy is definitely the next step to move ahead. And now Dr. Singh, tell us how we can move ahead.
Yeah, this definitely moves the needle now to the flip side of what you were discussing. So I love that walkthrough of hypoplastic bone marrow disorders, and now we're in the domain of hyperplastic bone marrow disorders. So I love that. I had PNH in my mind. I was like, I want to talk about PNH, but you just stole the thunder from me. So, but that's very high yield, the CD55 and 59. But if you pick apart PNH, you'll see also, what else do you have with PNH? You'll have thrombosis. And actually, it was interesting. Ravi had a tweet this morning asking about what kind of conditions cause both thrombosis and bleeding. And actually, PNH can be one of them too, where you can have both bleeding and also have clots. And specifically, they always highlight in textbooks, Budd-Chiari syndrome can manifest with PNH as well. And you also have iron deficiency, if I believe, because you have quite a bit of hemosiderunuria, right? So I would look for iron deficiency in this patient. Is that correct? I don't know. Get them thumbs up, thumbs down. I don't remember.
You're right, because like when you have intravascular hemolysis, you will lose the iron, as you mentioned. Yeah.
Right. When we didn't get hemolysis or labs, hemolytic labs, we didn't get haptoglobin, LDH, and so on. But then again, the retic count, that was a very, very important comment that you made about retic count, because we have anemia, right? So this retic count may not be truly reflective of what the process is going on in the bone marrow. So the retic index is very valuable, and it could indicate that there's an elevated retic index, which then puts us back into the domain of either blood loss, sequestration, or a hemolytic process, which could be it could be anything from MAHAs, autoimmune, to non-autoimmune phenomena, MAHAs, and so on. Hyperplastic bone marrow does signal processes where you're making a lot of different products, but they're all in disarray. So definitely myelodysplasia definitely comes to mind. Myelofibrosis, again, epidemiologically, the patient would not manifest with this process at an early age. Myeloproliferative disorders. Now, blasts, I would expect blasts in a leukemic process here. So I guess we can comfortably move away from exploring that area, but definitely myelodysplasia. But then you do see splenomegaly with myelodysplasia. And you eloquently had mentioned about, maybe you didn't mention about -5q deletion. If you do the cytogenetics, you would see that. And you tend to see on the bone marrow a cell called a I don't know how to say, pseudo-Pulgar-Hewitt cell. So there's certain characteristics that the bone marrow may signal that could indicate a process like that. When you have, you had mentioned about B12, folic acid, and so on, you'd see hypersegmented PMNs. And then you also mentioned about various immunological processes, medications. I don't see any medications that could be potentially causing this process. So I'm sort of standing with one foot in the MDS, MPL, and so on domains, and we'll see what Hans has to offer. Any final thoughts, Kirtan?
Dr. Singh, you mentioned everything eloquently, covered all the bases. I also love the drug part, which you mentioned, which I actually missed earlier, that you should always look at the medications which patient is taking, any supplements which patient might be taking. So thanks for teaching us that point, that how medication history can be vital. Rather than going for $1 million workup, we can just look at the medications and maybe get the diagnosis. Thanks for pointing that.
Right.
Now, Hans, please enlighten us and share your schema.
One more thing I like to throw out there is the great mimicker, SLE. We are in the epidemiological age for cytopenias, and we've known from various VMRs that lupus can always have. We've seen a couple of weeks ago with JAK seronegative lupus. We've seen all sorts of manifestations. So I just want to make a plug for lupus. Take it away, Hans.
Yes, I don't know what other tests you would suggest. to prove the diagnosis. Maybe somebody has an idea. Otherwise, I'll just mention one more that was being done.
Yeah, please, and for the sake of time, enlighten
Okay,
us.
for the sake of time, nowadays we would do a fluorocytometry of the blood cells, as the white blood cells as well as the red blood cells. And during the fluorocytometry, they found lack of CD55 and lack of CD59. And that gave away the diagnosis. And it was already mentioned by Rabi and by Kirtan earlier in. So the disease that we have, and I was just looking it up myself, it is PNH, paroxysmal nocturnal hemophilia, or hemolysis. It's an autoimmune disease. Actually, it is a mutation in an X-linked gene, the PIGA gene, which is the anchor that anchors the CD59 and CD55 genes into the membrane of the blood cells. And it's the blood, the white blood cells, as well as the platelets and the thrombocytes. And that's why we do have pancytopenia. That's why we have low white blood cells and relatively low red blood cells and thrombocytes. CD55 inhibits, I think, C3 convertase, and CD59 inhibits the insertion of C9 polymers, and thus the formation of, I think, the membrane attack molecules. So the patient will show a hemolysis in the blood. Therefore, it should sometimes be possible, probably if the disease comes in bouts, it's a little bit better and a little bit worse. So the urinalysis can show blood and it can be normal again. Treatment in the past, I think all we had was blood transfusions. In the meantime, we have a medication, and we all know it because it was mentioned several times in VMR. It's the eculizumab, and it inhibits CD5 convertase and thus the formation of the membrane attack complex. Now we have a newer medication as well, which is something which competitively binds to C3 and inhibits C3 convertase. So we can inhibit the entire process. So the treatment nowadays would be a lot better than in the past. I was looking it up, this case, when I was reading it up on a Harrison, just to see how a case would look like. I was really amazed to find out even before the final exam or final test.
Yeah, great case, Hans. Thank you. That was remarkable. I really appreciate.
I hope it was interesting.
Oh, it's very interesting. It's just, rather than the diagnosis, is just the journey was so enriching through all of the hematological landscape, and then learning. I mean, I learned a lot of stuff listening to Kirtan, or even being reminded about all the potential. Look, we talked about MDS, and I think PNH is part of the spectrum of MDS along with aplastic anemia. So it's very close, and we got to at least learn by dissecting this really invaluable case.
I have learned it is an autoimmune disease, and it would be a benign proliferative disease in the bone marrow. Therefore, we have a hyperplastic bone marrow, and we have T cells which destroy the product, the protein, the anchor of CD55 and CD59. So it's basically an autoimmune disease in the bone marrow.
Absolutely, yeah. And you know what's remarkable? You always think about like TTP, good patches, all these different conditions. Even we learned Beck's triad for cardiac tamponade, but I've seen many cases where you don't get the triad, you don't get the dyad, you don't get the pentad, cholangitis, and so on, ascending cholangitis. So this is also a case, somebody had mentioned that there's no thrombosis here. Maybe within a day or two, the patient will manifest with thrombosis, and then you'll have all the requirements of the criteria for PNH. So learn the pentad, dyad, tetrad, and so on, but you won't always have, just like TTP, you won't have the pentad manifest at one time. Any closing thoughts or reflection, Ketan?
Yes, thank you, Dr. Singh, for those brilliant reflections. And I would like to mention just one final point, that you know how sometimes names can fool us. So if you think about the PNH, it just states that patient has paroxysmal nocturnal hemoglobinuria. But if you think about it, all three of those elements could be wrong. I mean, it couldn't be paroxysmal. It may be, it happens continuously. It may not be nocturnal. It can happen even during the day. And finally, it's not just about the hemolysis because it's a stem cell disorder. So the CD55 and CD59 are not just limited to red blood cells. They are present on white blood cells. They are also present on platelets. So you can imagine if we have defect in CD55 and 59, that not only RBCs will suffer, but even WBCs and platelets will suffer. And that's why PNH is one of those rare disorders in which, despite getting the hemolysis, which would make you think of hyperproliferative reticulocyte count and everything, but still you are getting pancytopenia. So that's, kind of paradox for PNH because of the way the CD55 and CD59 works. So that was one of the interesting things which I wanted to mention. And I also applaud that how Dr. Singh mentioned that it is along the spectrum of MDS and aplastic anemia. So it is indeed true because after all, it's a stem cell disorder, just like MDS. So there have been cases in which, people have been diagnosed with PNH for quite some time now. And eventually, if you look at the repeat bone marrow biopsy, then they will have worsening of the blast cells. There will be numerous immature cells there. So now we can say that PNH has transformed into the MDS, and eventually it can even transform into AML when the blast count exceeds the 20% threshold. So all three of them are linked. So whenever you see the hyperproliferative bone marrow, it's imperative that we think of PNH because of the epidemiology of the patient. So that was my take home message from this. And now please take us home, Sammy. I have already seen excellent teaching points on the whiteboard and I can't learn to hear from you.
Sammy, thank you.
Thank you so much for this amazing case, Hans. You did so great presenting it. I know I think it was your first time and I really want to applaud you. So thank you so much. And also great discussion by Kirtan and Ravi, and also the chat was brilliant. So thank you all so much for participating. I learned a lot. Because of time, I will just go over some quick teaching points. When we see fatigue, we should think that it's very non-specific. It has a very broad DDX. We should think of anemia, systemic inflammation due to any cause, maldigestion or absorption, endocrinopathies, and also organ dysfunction. Any organ dysfunction can cause fatigue, especially liver, lung, heart, kidney disease, but also Ravi reminded us of neurologic disease. Look for other clues. Is there dyspnea? Is there signs of icterus? Are there signs of chronic liver diseases, etc.? When we see gum bleeding, we should always think about thrombocytopenia or platelet dysfunction, von Willebrand's disease, acquired hemophilia, vitamin C deficiency, excessive trauma, but also local inflammation or infiltration, for example, seen in certain types of leukemias. Then Kirtan taught us the amazing heme pearl that whenever we think about the hematologic cause of the symptoms, we should never discharge a patient without a peripheral blood smear, which Ravi taught me is a window into the bone marrow, and also always get the reticulocyte count because it's such high yield. Another pearl is the more cell lines are down, the more likely that bone marrow is the cause. But don't forget, we can also have peripheral destruction and bone marrow disease, for example, which could be seen here when you have peripheral destruction and insufficient proliferation of the bone marrow. Then Kirtan taught us this amazing approach to pancytopenia. You can have deficiency of raw material, disease of the stem cell, for example, seen in aplastic anemia, myelophthisis, for example, infiltration by solid or liquid tumors, granulomatous or storage diseases, but also myeloproliferative neoplasms, for example, primary osteofibrosis. The other thing we have to think about is peripheral destruction, for example, seen in SLE, which we also thought of, CLL, which cause all sorts of autoimmune hemolytic and anemias and thrombocytopenias, and also tick-borne infections tend to cause these symptoms. Then Ravi taught us PT is more specific for factor 7 and APTT is more specific for factor 8 and 9, but both can be elevated in a number of disorders, and especially of the common pathway 10, 5, 2, and 1. I always think about Euros here in Austria. There's a 10, 5, and 2, and 1, so I remember it like that. That's the common pathway. Then Keaton taught us the great pearl that whenever we see low hemoglobin and the reticulocyte count is elevated, we should not disregard a hyperproliferative disease because it can still be hyperproliferative or inadequately low response of the bone marrow. And we should always get a reticulocyte proliferation index called RPI because it adjusts for the hematocrit and therefore standardizes, and you will see much more hyperproliferative anemias when you do this. And anemia, we can distinguish it by the MCV, micronormal and macrocytic, and also very importantly, as we learned today, the reticulocyte count, hypo versus hyperproliferative, and these two markers can help you a lot distinguishing those two. And lastly, we had this amazing diagnosis of PNH, which is also one of my favorite diagnoses in medicine. It mostly affects young people. It's an acquired X-linked disease, so it's very fascinating, and notoriously it causes peripheral cell destruction, but also thrombosis. So yeah, thank you, Hans, again for this amazing case, and hope to see you all tomorrow.
All right, absolutely brilliant. Thank you, Sammy. That was a great, concise sort of walkthrough of all the teaching points. So appreciate it. Thank you, Keaton, for coming on today and helping as well, and Madalena for the scribing. Take care, everybody. See you tomorrow. Bye.